Thanks for joining us. If you missed the last session, we stopped or we talked about insertion. We stopped at insertion, and now we're talking about session 2 is about securement, superior securement. So securement and stabilization, to me, people interchange, but they're very two distinct, different terms for me. Securement is to secure, or is to make free from risk of loss. It's attaching it to the body. That's what when I talk about securement, that's what securement means to me, attaching it to the body. Stabilization, however, is at the skin level. It's to hold steady. And we don't want that catheter to piston in and out. We want to prevent the micro pistoning because that simply drives the bacteria through that extrinsic pathway to risk the bloodstream infection. Here is an example. You can see very poor securement. It is attached to the body, but we've got, an IJ insertion here with a securement dressing that's over top of a beard. The sutures are pulling on the skin. The sutures are very loose, and the site, you can't see the site exactly, but it's exposed. Stabilization, you can see this catheter. Here is where the sutures are. You can see it. It's really blown up. This little channel right here was for a suture, and guess where it was attached? Right here where these two pus pockets are. This is not good at all. And you notice the flexion of this catheter. It's pushing on this side, and the skin is really building up on the right-hand side of this insertion site, where it's really gapped right here. So we got a big giant gaping hole, pus pockets that are coming out. This can't be good whatsoever. When I talk about the modalities of securement, we think of transdermal, cutaneous, and subcutaneous. Transdermal is through the skin. It's the sutures. A lot, we see this in dialysis catheters and CVADs, the neck and whatnot. The cutaneous is the adhesive types of devices. This is a very common one you see. There's a half a dozen or more variations of this. We also link or group securement dressings into this type of category. There's a couple of different ones out there, and I am putting tissue adhesive, although this is a very different product. So we're going to talk about those in the pros cons, but I do want to draw out that particular product. Subcutaneous securement. This is the one and only secure cath. It's anchored by feet under the skin, and really is what I have the most questions about and curiosity. People are very curious about this and have a lot of questions. So I'm going to go into this really more in depth to answer some of those questions that are out there. Speaking of curiosity, my curiosity led to this little study, and it really was more of a demonstration, but I had about 23 different securement modalities and configurations. So the different securement methods with and without dressings, and this is the chart that you're seeing in front of you. All of these are without the dressing, and these are with the dressing. So you can see the average pull force was about almost 2.5 times as much with the dressing, which really shocked me that the dressing had that much influence over the amount of force that had to be exerted for failure to occur. So it really just kind of smacked me in the face a little bit, and I went, man, this is really important. We got to keep these dressings on. So the pros and cons: transdermal. If the sutures are intact, it does attach to the patient. However, it doesn't really protect that insertion site, from migration whenever you pull the dressing off. It's very difficult to clean underneath of those devices that are sutured down. The sutures will deteriorate and loosen and even erode the skin over a period of time. Needle stick injuries are really an issue. You know, I was surprised whenever I started looking into this. I read an article about 6 weeks ago that about 40% of the healthcare workers that had contracted hepatitis was directly related to needle stick injuries. So it's really something that we need to be more conscious over. And when sutures are placed in, oftentimes, I don't know if you've ever been around a patient that was alert that had these, they complain more about the sutures going in than the line, honestly. For a long time, CDC and INS and other agencies has said, listen, it's not a securement device, it's a wound closure, we don't need to be using it. The cutaneous category, the pros are you can completely clean all the way around the device, everything that would be under the dressing. There's no risk of needle stick injuries. However, when you take it off, the catheter is at risk for migration, pistoning, or even dislodgement. We do have to replace these devices because of the skin. You know, it sheds, the adhesive weakens and whatnot. And during that, replacement, if it's a device or a securement dressing, then again the catheter is at risk for dislodgement and pistoning and whatnot. With adhesives, you can have irritation and skin injury related to the adhesive. However, tissue adhesive is a little bit a different type of product. This has the property of sealing the insertion site. It is bactericidal, so whenever the drops of glue hits the bacteria, it kind of freezes them in place, and then it sucks all the water out of the cells, you know, for a one-time kill. But the most impactful thing about this modality is that it helps to prevent bleeding and seals off that site. And as of today, I have not heard any or seen any research that shows that this type of adhesive causes any type of skin irritation or injury. The subcutaneous securement device, that's the SecurCath again. It stabilizes the catheter at the insertion site, and it allows for complete cleaning of the catheter when you remove the dressing without the fear of micropistoning, migration, or dislodgement. We don't have to worry about any type of adhesive, skin-related injury, and despite what people think sometimes, that these little feet that go underneath of the skin are not sharp. They will not poke you. They will not cut. They do not lacerate skin or harm the skin in any way. And the greatest thing about this is you just need one. There is no reapplication, and this device can stay on for 3 days, 3 months, or 3 years, however long the vascular access device is in. The cons really for this is you just simply need to understand how to use it. You need to have the proper education. This is not a device that you can look at and instinctually know how it works. So with any other medical equipment, you need to have an in-service. You need to know how it works, which fortunately, I'm going to give you that in-service today. So this is the insertion of this device. I'm going to run through how to do this, and then I'm going to show you the video. So first, you squeeze the feet together. You come in from the side. You're going to roll the toes in, angle the legs up just a little bit there, drop the heels in, deploy the legs and the feet, and then pull back on it. That sounds complicated, but watch the next 10 seconds. Put the feet in, come in from the side, angle up, legs in, deploy the feet, and pull back. And that's how you put it in. This is the big mystery, and we're like, what? Everybody's like, what is it? How do you get this in? How do you get it in? Well, that's how you do it. So another big question that I get is, how do you get the thing out? And an observation and a comment or an observation is, hey, this thing is going to grow in. You're exactly right, because it's going to grow in because there's not that micropistoning. And is that a bad thing? No, because what is our skin? Our skin is our natural barrier against the outside world. It's what protects us from the cooties that you know, are on the skin. If this skin has grown around these legs and the catheter and completely heals, then we don't have to worry about the catheter pistoning in and out and pushing bacteria into that insertion site, right down that extrinsic pathway, right into the blood system. So that is a positive, you know, for me. It really has, over the years I've used this device, it is really significant in preventing, you know, that micropistoning and bacteria tract. So there's two ways to get it out. Everybody wants to know. There's a fold method and there's a split method. The fold method is simply doing the exact opposite of what we just saw in the video. You do it in reverse. You fold it, you hold traction across it, and you pull the feet through the exit site. Now, sometimes, you know, the patients are very sensitive and they may have a little bit of discomfort. Anytime they have any kind of discomfort, whatever you're doing, you stop, because it's not the device, it's the way you are using the device that's causing the discomfort. So what you're going to do with this on the second method is a split method, and you take the catheter out. You're going to cut right down the center of that with a pair of scissors. It's going to come apart. There's going to be two pieces, and you can take you know, each piece out by, you know, making the leg parallel to the skin and doing just like you saw before with the fold method of going in. It just parallel, lay the leg down and pull traction across the insertion site and back the feet out the exit site. The 90 degree is what I want to show you today, is because, and this is the surefire way that you will minimize any type of risk of discomfort all the time with any type of removal. Some people do this all the time, but again, there's a little bit more involved because you got to get the scissors out, you got to cut it and whatnot. But this is very simple to remove at this 90 degree angle method. Let's see let me show you what you're going to do here. What you're going to do is you're going to take your finger and you're going to put right over the foot. How do we know where the foot is? Because the foot follows the fin. So whatever direction this right here is pointing, that's the same direction the foot is pointing. So the foot is pointing straight out here. You're going to take your finger, place it right over that insertion site or the exit site where the foot is, and you're going to push gently but firmly right into the insertion site, and then just like a ninja, you're going to pluck this thing out, lickety split. And I'm going to show this to you now. Here we go. Get in focus. Over the foot and right out just like that. Then that is quicker than 3 shakes of a lamb's tail right there, folks. I'm telling you. This right here is if you have any issues with any of the other methods, this is the way you are guaranteed to remove it without any problem whatsoever. So how do we keep the catheter secure and stable? Well, we look to the INS standards, and what's interesting about the standards is of some of the language that they changed in the 2021. Of course, securement is to prevent complications like unintentional loss of access, but they speak about the motion at the insertion site. This is the micropistoning that we're trying to prevent. It is absolutely a huge factor, is believed, that is contributing to the bloodstream infections. They go on to say, you know what, securement and stabilization is there to protect the site. It's there to provide a microbial barrier. We want to make sure that we don't damage the skin as well as secure it to the patient. Here is something that, man, I tell you what, I have been in some heated discussions with various people about when to change the dressing. Everybody has their own opinion. Oh, Matt, it doesn't matter if that little edge comes up. I don't want to. open the dressing up just for that little fold that's coming up, the little corner. Here is that little, what that little fold of that corner is. It's the beginning of the end of the dressing. That's what that is. The standards tells us exactly what we need to do. We need to change immediately if the dressing integrity is disrupted. But they go one step further and they say what dressing disruption is. And that is a lifted, detachment at any border edge or within the transparent area of that dressing, especially when there's moisture drainage or blood that's present. You know, when you look down the right-hand column and you see all these dressings are nice and tight and really adhered on all bordered edges. This is what you commonly see. I've been in hundreds of facilities and it's the same thing. You know, we have an issue with dressing disruption. So here's a poll. I'm going to ask you guys this. So get out your little clickers, and if you want to launch the poll, Stephanie, here's the question: how often do you change a CVAD dressing in your facility? I ask this everywhere I go. I ask people this, and invariably I get the same answer, and it's not what you really expect.
So it looks like 84% say every 7 days.
84%, and invariably, that's exactly what we hear. What I hear every place I go. But this question doesn't ask how often does your policy say to change your dressings in your facility. It's how often they really are changed in your facility. And it's much different. You know, most people think, we don't really have a problem with that. You know, and the likelihood of your dressings lasting 7 days, it's really the exception. Honestly, it is. This is a study by Richardson in 2015. It really shows, and this was not a small study, you guys. This was a large study, and it really shows, you know, what the rates of dressing changes. Most of them didn't even last for 2 days. You know, and this dressing number 4 was a securement dressing, and it didn't even last 3 days, you know. So especially this is true in your ICUs, you know, and why is that important? Because in 2012, Tensit does a massive study on dressing disruption, and we know that the dressing disruption is an independent factor for bloodstream infections. And you see here, you see the first dressing, second, third dressing disruption, and how the risks go up and up and up. You know, it is a significant issue, and it's something that we need to be very, very conscious of. If you're not measuring it, then you're not, you really can't say how often you're changing your dressings. Tensit's conclusion was we need to develop, validate, and use more adherent dressings. You know, so go look at your dressings. You know, and and hopefully what you think, the 84% is yes. Hopefully it is 7 days. I seriously doubt you're going to find that. I had the privilege of being in Shelley DeVries's hospital back a while ago, and I was doing some training with the clinicians, and the clinicians were talking. You know, a call came up and said, "Hey, I'm going to go do this dressing change. You want to come with me?" And I said, "Yeah, sure, I'll come with you. No problem. Not a big deal." And so I went with them, and I walked in, and I was like, are we in the right room? And she's like, well, yeah, this is the right room. And I'm like, that dressing hadn't been on there for more than 24 hours. Like, why are you changing that dressing? And she's like, it's been on for 7 days. I went over to the patient. I did not believe it. I looked at the date, and it was, in fact, had been on for 7 days. And the only thing I could say is, how is this possible? And this is the study that Shelley did with gum mastic, mastisol specifically, and this is, you know, a really important article. Over 30,000 lines that they assessed over about a year and a half. Their baseline, 45% did not have all four corners intact, and 15% the site was exposed, which they called non-intact. After they implemented this measure, they had 96% dressing adherence, and that was at 7 days, with only a little over 2% with the insertion sites exposed. That was significant. And with all of this, they had absolutely no medical adhesive related injuries. And what did they do? They started using it. They just started using it. So in the standards, when we look at dressings, it tells us evaluate the benefit use of gun mastic liquid adhesive when enhanced adherence is needed. Well, when you look at Richardson and you discover that your dressings may not be lasting for 7 days, you're probably going to say, we need something that sticks better and that will stay on for a full 7 days. And part of what the standards also say is, you know what, think about combining different securement measures to help reduce the complication. Very, very few people are actually tracking their dislodgements or migrations, and definitely not tracking their dressing disruption. So when you have that information, then you can actually say, yes, we need some help. This is me putting a line in. I'm using Mastic, and I'm going to show you how long it takes to apply this. You're going to simply paint a window around the edge. It's not like you got to paint this stuff on. It takes 7 seconds, and in 7 seconds, you can save a dressing for 7 days. That's what I learned when I was at Shelley's Hospital, and it was absolutely amazing to me. So here really is the summary. Dislodgement and bloodstream infections are preventable complications. If you don't believe this, then you need to reevaluate, how you look at this, because they certainly are preventable. The government thinks bloodstream infections, obviously, are central line bloodstream infections are preventable, but there's no doubt that dislodgements are preventable as well. Securement is attaching it to the patient. It's also stabilizing it at the skin level where the catheter comes out of the body. And the dressing adherence is a large component of that securement. It's very, very important to keep that dressing on. And we want to look at combining technologies to maximize our ability to hold catheters in and prevent migration and dislodgement. And I can tell you from personal experience that using Mastic made a huge difference from the clinical experience that I've had. So that pretty much wraps up the dressing, how to help secure and stabilize the dressing. And I hope this was helpful for anybody that attended.
Thank you, Matt,
so
much. We appreciate it. Yes, we do have a couple of questions that have come in. Thank you again so much for our audience. This does conclude the presentation. We are now ready to address just a couple questions from our audience. Given our time constraints, we have time for just one question. So I'll ask that of you now, Matt. So when removing the subcutaneous securement device, is there any risk of injury to the clinician that is doing the removing?
You can take a Securicath and take the little feet and literally punch into your hand and scrape across your skin, and it will not cut you, puncture you, or in any way harm you. So simply by removing it, there's no chance that you're going to be injured. And that's what I have an image of the profile of that foot. And if you can imagine what a golf club looks like, it's a little shaft that comes in and a nice round ball. These edges are beveled and they're polished. It's memory metal, it's nitinol, so it doesn't bend, it bends, but it doesn't crease or break. So you can't accidentally break a foot off and then poke yourself with it. It just doesn't. It doesn't do that. So no. To answer the question is there's no concern or worry about a needle stick injury or a sharps injury with this device.